So Scott, I'm curious because often a pushback or a blame has been put towards CMS that in the original design of benefits, there was this kind of black or white. So once you went into a hospice track, you couldn't get a blood transfusion, you couldn't get these services provided. So it literally became, I'm not putting them in until, basically they've got 1 foot in the ground. And that it's such a shade of gray that literally, as Brian mentioned earlier, and Mike mentioned, once you have a patient diagnosed with metastatic solid tumor, you're literally looking at what could be a 1 to 2 year expected survival. But the system doesn't really allow for that. It has these black and white determinants of when things can be done.
Right. Well, I mean, that's what happens when you set rigid metrics as a way to enforce standards from a remote bureaucracy over a system that's very heterogeneous with,
But tell us what you really feel.
Yeah.
All right.
It is a problem because now there's a sense inside Washington and CMS that there's overutilization of hospice because they're looking at data showing that the average length of stay is increasing, and in their reaction to that is, well, we have to change the reimbursement scheme to disincentivize this, and then they bring down reimbursement, and that throws a lot of hospice providers out of business. I mean, this is a cyclical trend in Washington in and around CMS where you have this yin and yang between, too much and too little. I think it's very hard I think this is a problem of trying to set clinical metrics from afar, and I'd much rather see it in the hands of payers who are closer to the provision of care. I was just going to say, I practice as a hospitalist, and I'll since we're talking about anecdotes from our clinical practice, I'll throw one in. We see a lot of patients, I see a lot of patients that I have to make DNR in the hospital, and those conversations, I would say, have gotten easier over time. There's more of an awareness on the part of patients around what they do and don't want, and there's patients coming in more sophisticated about thinking about these things, but there's still a lot of patients that we're making DNR in the hospital that me and my hospitalist colleagues always feel it should have been addressed on the outpatient side. And resentment's a strong word, because I don't want to say we resent their physicians for not doing it, but there is a little unhappiness on the part of the hospital-based physicians when patients don't have that.
So I think what you just said is accurate, and I think if you think about why patients, quote, cost so much at end of life, it's because they're in the hospital, right? So acute care, in the last 3 months of a cancer patient's trajectory, acute inpatient care is the cost driver for those patients. And sometimes it's because they got chemotherapy when they shouldn't have, but more often I think it's because of symptom burden and an inability to have developed the system to deal with that symptom burden. Now, I consider that a system failure, you see, and I think we should not for a second pretend that this is going to be an easy fix. First of all, I don't think it's got anything to do with reimbursement. I think paying a doctor to have have an EMM code where he has a discussion with the patient for an advanced care planning session is nonsense. That is not going to improve care. Now, it may give a slight push to some doctors, but every oncologist who does this knows that this is a journey. It is not a 15-minute time slot. It doesn't work that way. The second thing that's really, really important to remember is, as we look at the way it's being done now, I'm sure I will make some doctors really mad at me when I say this.
Well, not just for this. You're just on the roll.
I'm good at it. We got to think about whether the system is the right system. So you can embed it in the fabric, but since I live in the real world, good luck with that one. I think the question is whether you have to take it out. So when I say take it out, what I mean is this. There are studies that show that when patients hear from their or are told by their doctor that they have a terminal disease, they think they're being treated for cure. Incontrovertible evidence that's true. There's data that says that patients who are given bad news by their physician tend to view that physician as less compassionate. So there's something wrong here, right? I mean, we're telling doctors they got to do that, and yet patients are telling us that the way we're doing it isn't working. So the question is, do we take it out? And so the health plan perspective is, and Aetna has this program called Compassionate Care, we have specially trained nurses, that's all they do every day. They're extensively trained, and it's tied to an enhanced hospice benefit so that you can continue to get whatever therapy your doctor wants to give you. It'll be paid. But you also have this interaction with someone who's really good at having this advanced care planning discussion. What's important to you? if it came to this, what would you want? The goal is not to enroll them in hospice, and the goal is not to get a DNR. The goal is to have the discussion. And I just think we should start getting comfortable with the idea that that kind of, and it doesn't have to be a palliative care physician. I think a palliative care physician has a distinct role, but there just ain't enough of them. I mean, the truth of the matter is they're in hospitals and typically big hospitals. Is there a better way to deliver this vital clinical interaction? I don't know.